Good morning. So you may be aware that 16% of multiple choice questions on the boards are fluid and electrolyte questions. So it's a fair number of them. And so we're going to have two sessions today. This is the first of them, where we'll go over some sample questions that will cover some of the material that you've already heard and some of the material that you're going to hear later in the day as well. So let's launch straight into it. I have no disclosures. So the first case is a 35-year-old man with a bipolar disorder maintained on lithium for 10 years who's referred to you for chronic polyuria and polydipsia. He complains he has to void once every hour. Thank you. And his serum sodium is 144, creatinine is 1.9, osmolality 292. He's making 5 liters of urine with a urine sodium of 28 and a urine osmolality of 190. And the question is, all of the following might be appropriate in the management of this patient except. So notice the tricky wording of the questions. This is actually a wording that's taken out of a board question. Except thiazides, salt reduction, discontinuation of lithium, fluid restriction, or amiloride. Might be a little early in the morning to think. Okay, let's see what people think. All right, so the wording of this is a little challenging. So most of you chose D, fluid restriction, which is correct, or to put another way, the only answer that's incorrect. A few of you chose B, which is dietary salt reduction. So let's go over that a little bit. So firstly, there are obviously multiple ways you can approach each question. I usually try and hone in on the major abnormality, which here is polyuria. And as Dr. Mount discussed in the last session, polyuria, defined as more than 3 liters per day, can be either due to an osmotic or a water diuresis. And the key step to distinguish between them is to calculate the osmolar excretion rate, how many osmoles the patient is putting out per day, normal being less than 1,000. So if it's less than 1,000, then all that additional volume has to be water, hence a water diuresis. If it's greater than 1,000, there have to be additional osmoles. Either the patient's getting additional saline, or they're having hyperglycemia and the glucose diuresis. They're getting TPN and getting too much protein or mannitol. If it's a water diuresis, the two possibilities are diabetes insipidus or polydipsia. Sometimes you can tell the difference just by whether the serum sodium is high or low. And so in this particular case, if you calculate the osmolar excretion rate, it's substantially higher than 1,000. The serum sodium was a little on the high side, so most likely this patient had diabetes insipidus, and he was on lithium, shown here. So there's a good chance that this patient might have had lithium-induced nephrogenic DI. So about half of patients on chronic lithium therapy have some sort of urinary concentrating defect, and about 20% have overt polyuria. So in terms of how you treat nephrogenic DI, it's always challenging. If there's an underlying cause, you treat it. As Dr. Mount discussed, it's always hard to know whether to recommend that lithium is stopped or not in these cases. Occasionally, you can give supraphysiologic doses of desmopressin, and patients with relatively mild forms of this can sometimes respond. NSAIDs and COX-2 inhibitors can improve the concentrating defect. And then things that decrease the salt delivery to the intermedullary collecting duct can help. Now, these don't relieve the concentrating defect. All they do is reduce the amount of obligate solute loss, and therefore they reduce the amount of free water that has to be excreted along with it. So this is essentially just a technique to reduce polyuria and make these patients' lives manageable. And so that includes low salt diet, thiazides, and amiloride. So low salt diet was an acceptable treatment for this disorder. What you don't want to do is obviously to fluid restrict someone with diabetes insipidus, which would lead to not only potentially dangerous dehydration and hypernatremia. Next case, a 55-year-old man with colonic carcinoma undergoes resection of his tumor and diverting colostomy. Post-op, he has an ileus, so he has to have TPN. And 4 days later, you're called because he has hypernatremia. He looks euvolemic, but his sodium is 151. Urine osmolality 480, urine volume 3700, urine sodium 30. Which is the most likely cause of his hypernatremia? Is it central DI, nephrogenic DI, osmotic diarrhea, osmotic diuresis, or excess IV saline? Okay, let's see. Good, so most of you chose D, osmotic diuresis, which is in fact correct. So following on the same algorithm that I just showed you, if you calculate this patient's osmolar excretion rate, urine output times urine osm, it's greater than 1,000. And given the setting, the most likely cause is a urea osmotic diuresis from the TPN, which we see quite commonly. Another way to approach this, so this is a patient with hypernatremia, is to ask the question, why does the patient have hypernatremia? So when I see a patient with hypernatremia, I ask the question, are they appropriately stimulating ADH and concentrating their urine? If they are, then they should be able to increase their urine osm to greater than 800. And when you see that, the cause of the hypernatremia must be extrarenal, meaning either insensible water losses without adequate intake of water, GI free water loss, so an osmotic diarrhea, or salt intake without water. If the urine osm is less than 800, as in this particular case, then the patient is having renal free water loss. And the two causes of this, again, are either diabetes insipidus, an actual concentrating defect, or osmotic diuresis. So you can get to the answer this way as well. Next case. A 17-year-old woman who is otherwise fit and well and on no medications presents with a history of polyuria since early childhood. So her sodium is 141, osmolality 285, urine osmos 210, and she's putting out 4 liters of urine per day. After 4 hours of water deprivation, her serum sodium is 146, serum osmolality 298, urine osm 250. She then gets 10 micrograms of intranasal DDAVP, and 1 hour later, her sodium is 143, serum osmolality 292, urine osmolality 585. Which of the following statements could be true? She's entirely normal, since her baseline serum sodium is normal. Water deprivation test is non-diagnostic because water deprivation was not continued for long enough. She has central DI, she has nephrogenic DI, or she has an osmotic diuresis with washout of her medullary interstitial concentrating gradient. A little bit more challenging. Okay, let's see what people thought. All right, good. So most people thought she had central DI, which is what I would agree with. So in a patient that has renal water loss, the first question you want to ask is there a defect in urinary concentrating ability when ADH release is maximally stimulated? So if you have a patient that is hypernatremic at baseline, then you already can look at their baseline electrolytes and ask the question. The issue is that many of these patients don't have an abnormal serum sodium and osmolality. So patients with diabetes insipidus often drink because they're thirsty and manage to lower their serum sodium and plasma osmolality into the normal range. So in order to maximally stimulate ADH, you actually have to increase the plasma osmolality. I generally do this with a water deprivation test, although you'll see now that there are some clinicians, particularly endocrinologists, that are starting to do this with hypertonic saline. I can't say I have any experience with that, and it seems unlikely that the boards will ask you about that. So if you do that and the urine osmolality is greater than 800, then they don't have a concentrating defect, they don't have renal water loss. That's not terribly interesting. But if it's less than 800 and then they have presumably diabetes insipidus, then the next question is it central or nephrogenic? And that rests on whether you can reverse the concentrating defect by giving additional exogenous ADH. So if you give DDAVP and they do respond by concentrating their urine, then they have central DI. And how much can you concentrate the urine? You should be able to increase the urine osm by at least 50% in the first 2 hours. It doesn't return all the way to normal initially because patients that have chronic polyuria have washout of their interstitial gradient. But it should increase by at least 50%. If it doesn't, then these are patients whose tubules are unresponsive to ADH, which is the definition of nephrogenic DI. Okay, next question. An 87-year-old woman tripped in her bedroom at home and is unable to get up. She's found by her neighbor 3 days later and brought into the ER, and on exam she's got a broken hip, appears dehydrated, and is making small volumes of very concentrated urine. And her sodium is 157, BUN 35, creatinine 1.5, urine sodium less than 5, and urine osmolality 850. Which of the following statements about hyponatremia is most likely to be true? Her hyponatremia is most likely to be due to osmotic diuresis. She likely has underlying DI. The hyponatremia is due to insensible water loss. She has impaired concentrating ability due to CKD, or she has a hypothalamic lesion with severely impaired thirst. Make your choices. All right. Good. Everyone thought it was C, which I agree with. So this is a patient who's got a highly concentrated urine, so they don't have renal water loss. So it's got to be one of these extrarenal causes. And in this case, this is a patient who doesn't have access to water and is continuing to lose free water. So remember, insensible water losses are essentially free water. And that's why these patients become hypernatremic over time. Okay, next. A 45-year-old female underwent transsphenoidal resection of a large pituitary adenoma a week ago, and immediately post-op she developed polyuria. She was treated with DDAVP for 2 days and then encouraged to increase her PO fluid intake. She returns with change in mental status and has a seizure in the ER and is found to have a serum sodium of 120. Which of the following statements about her hyponatremia is true? Her hyponatremia is caused by inappropriate treatment of DDAVP. Her hyponatremia is caused by extracellular volume depletion. Her hyponatremia is due to central hypothyroidism, psychogenic polydipsia, or unregulated vasopressin release from the posterior pituitary. Okay. Good. Okay. So most of you chose E. Some of you chose A. So this is a... So firstly, these are the causes of central DI. And obviously pituitary surgery is right on top. When a patient gets transsphenoidal pituitary surgery, there are well-known series of stereotyped responses in terms of sodium and vasopressin metabolism. And so there are 3 potential phases, and patients can have just 1, 2, or all 3 phases of these. And those phases are shown here. So initially after surgery, there is so-called secretional arrest, a brief period of a day or 2 where there's no release of vasopressin at all. And these patients can behave like they have DI. And so usually these patients require some DDE-AVP post-surgery, and this patient got it, but just for 2 days. About a week or so later, these patients can start to have excess release of vasopressin, and that's due to degeneration of the pituitary stalk and release of preformed vasopressin. And then at the end of this period, which generally lasts a little less than 2 weeks, then we're left with the chronic situation, which is whatever remains in terms of neurosecretory neurons will secrete residual amounts of vasopressin. And in most patients, that will be adequate to control sodium. In a small number of patients, it's inadequate, and they will have permanent DI. So in a monophasic response, which is the most common, you would just get a brief period of essentially transient central DI that's treated with DDAVP, resolves, and they go home. In the second, which is what this patient had, you have a biphasic response that includes a period that starts about a week later, where the patient essentially has transient SIADH. And then the triphasic response, they end up ultimately with permanent DI. So this is the phase that this patient was in, and that was the reason for the hyponatremia. And it gets treated the same way you would treat a patient with SIADH, but being aware that it's transient. Okay, next patient. A 34-year-old male with alcoholic cirrhosis is admitted with obtundation and found to have sepsis, variceal bleed, and hepatic encephalopathy. He's treated with propanolol, octreotide, and lactulose, and gets 4 to 5 watery stools daily. And when he's seen, his sodium is 149, K is 3, bicarb 19, urine osmolality 855. And the question for you is about hyponatremia. Which of the following would be the best treatment to prevent worsening hyponatremia in this patient? Is it to cut down the dose of lactulose, octreotide, start some 5% dextrose, start hydrochlorothiazide, or start DDAVP? Okay. Everyone made their choices. All right, a little bit of separation here. So most of you chose A, reduce the dose of lactulose, which is what I would choose. There's nothing wrong with starting dextrose, which is what the other third chose, but it's not the definitive treatment. So this is a patient that has, again, hyponatremia, but with a fully concentrated urine. So this has to be hyponatremia due to extrarenal free water loss. In this case, in this context, it was most likely due to lactulose. So lactulose is an osmotic laxative that basically pulls free water into the colonic lumen. That's how it causes diarrhea, but it leads to free water loss. And that's shown here. So stool contents equilibrate across the colonic wall with the plasma so that they are essentially isoosmotic. So stools are always isosmotic. Under normal circumstances, that's due to mostly sodium, potassium, and accompanying anions. However, in an osmotic diarrhea, a large proportion of that osmolality is due to the osmotic laxative, in this case lactulose, and this pulls free water in with it. So the total stool osmolality is normal, but the tonicity of the stool, if you will, the amounts of sodium and potassium and accompanying anions per liter of water is actually markedly reduced. Okay, next case, and on to something a little different. A 64-year-old woman with ischemic cardiomyopathy and an EF of 15% is admitted with pulmonary edema. Her meds are as shown, so the typical heart failure patient. On exam, blood pressure is 93/44, heart rate 85, JVP 12, diffuse inspiratory crackles, S3 gallop, cool, clammy extremities, and 1+ edema. So her labs show that her sodium was 124. Rest of her labs are as shown. Urine electrolytes, when she's not getting a diuretic, sodium's 15, chloride less than 5, urine osmolality is 220. Which of the following treatments would best correct the hyponatremia? Is it IV saline, restriction of free water intake, hydrocortisone, dobutamine, or B and D? Okay, let's see what people thought. Okay, so most people agreed with me on E. You can argue a little bit about the treatment of heart failure, but I think this was a case of heart failure causing hyponatremia, and I'll explain to you why. So when I see a patient with hyponatremia, the first thing I want to ask is it truly hypoosmolar hyponatremia? Meaning that the plasma osmolality is less than 275, and it was in this case, but obviously we have patients that have high plasma osmolality due to other osmoles, usually glucose, and normal osmolality with pseudohyponatremia due to a lab artifact, but with the caveat that only occurs when lipids or proteins are extremely high, and only if the serum's been diluted before it's measured. A technique that's known as indirect potentiometry. So a quick call to lab would be able to help you distinguish that. So for these patients that have hypoosmolar hyponatremia, the next question is, have they appropriately suppressed ADH and maximally diluted their urine? And so maximally diluting the urine here means reducing it to less than 100, something that we should all be able to do. There's a common misconception that the maximally diluted urine is one that's less than the osmolality of plasma, and that's not correct. It's got to be less than 100. And if that's the case, the most common cause of that is psychogenic polydipsia, patients that are drinking water faster than their kidneys can excrete it. So also, with the same clinical picture would be low solute intake, for example, patients with beer-potomania. I haven't seen a case of this on the board questions, but in theory, they could ask about that. So for patients, all other patients whose urine osmolality is greater than 100, they have ADH levels that are too high that's driving the hyponatremia. And this could be either because the ADH is being released in an unregulated manner, which is SIADH, and I include in this hypothyroidism, which mimics SIADH, or because they have hypovolemia and volume-induced ADH release, either due to GI losses like diarrhea or vomiting, or renal salt losses due to adrenal insufficiency or diuretics, or they have relative underfilling of their circulation, either because their cardiac output is low, which as in heart failure, or because they're profoundly vasodilated, as in liver failure. And we call that effective circulating volume depletion, or effective arterial blood volume depletion. So these patients aren't actually hypovolemic. In fact, they're usually edematous, but the body perceives as if they're hypovolemic. And to distinguish between all of these cases, I use a physical exam. Obviously, volume status can distinguish between some of these. Urine sodium, which is low in volume depletion, either actual or perceived, unless it's due to renal salt wasting. I don't show this here, but sometimes uric acid is helpful. High, again, in volume depletion, low, less than 4 in SIADH. And then I always check TSH and cortisol because you may not suspect an endocrine disorder. So in this particular case, this was a patient who was obviously edematous and likely had heart failure. And in that case, the only thing that would reverse the hyponatremia would be to attempt to improve the heart failure. So if they're in a low output state, to give dobutamine, for example, and to reduce the balance of free water intake to free water excretion, which is what fluid restriction does. Okay, next. A 45-year-old male smoker presents with confusion and drowsiness. His only meds are bronchodilators and steroid inhalers. On exam, looks pretty normal. Chest X-ray just shows emphysematous changes, and his serum sodium is 116, serum osmolality 256, and the urine lights are as shown with an osmolality of 670. Which of the following is most likely to reveal the cause of the patient's hyponatremia? Is it a thyroid radioiodine scan, CAT scan of the chest, serum protein electrophoresis, echo, or assessment of daily fluid intake? Okay, should be pretty straightforward, I think. Yep, almost 100% going for B, which is what I would agree with. So this patient has hypoosmolality. He has obviously a high urine osmolality. As a quick tip, if the urine osmolality is very high, meaning more than 500 or so, it's most of the time that's due to SIADH. These other things are rarely given urine osmolality that high. So most likely this patient has SIADH, and sorry about that. And given that the patient was a smoker and had emphysematous changes, he's obviously at risk for lung cancer. And so small cell lung cancer is by far the most common malignant cause of SIADH. Yes, hypothyroidism can sometimes mimic it, and you could check a TSH, but the radioiodine scan would not help you here. Next, an 18-year-old woman with schizophrenia maintained on risperidone presents with a generalized seizure, and her sodium is 120, osmolality 252, urine osmolality is 90. Which of the following is the best treatment? 3% saline, normal saline, 500 ml IV bolus, tolvaptan, stop risperidone, fluid restriction. Okay, should be fairly straightforward. Let's see what people think. Okay, interesting. All right, so half of you chose hypertonic saline and a third of you chose fluid restriction. Okay, so I would prefer fluid restriction. I can actually understand why people would want hypertonic saline, and we can discuss that. So the most important thing here is that this patient has a very low urine osmolality. So this patient clearly has psychogenic polydipsia. Even though the patient's on risperidone, it's a potential cause of SIADH. The urine lights clearly don't show that. They show psychogenic polydipsia. The natural history of psychogenic polydipsia is that as soon as you stop drinking water, the sodium comes up extremely rapidly. So if you think about it, if a patient has a normal kidney and is able to lower the urine osmolality below 100 milliosmoles per kilo, they can excrete oftentimes a liter an hour of urine, mostly free water. And they're probably doing it while the patient's drinking. but the patient's drinking faster. That's why the sodium's so low. As soon as you stop the drinking, there's still continued excretion of free water until the urine sodium rises and serum sodium rises into the normal range. So until that serum sodium comes up, the ADH is going to be profoundly suppressed. They're going to have a profound polyuria, and the serum sodium will bounce up very quickly. So the problem isn't correcting the sodium. The sodium will correct very, very rapidly. In fact, it's often the other way around, that the sodium corrects too rapidly, and then we have a debate about should we try and suppress that, bearing in mind that this is probably acute and not chronic hyponatremia. And usually we don't, we just let the serum sodium come up. And so in this patient who has seizures, if you stop the fluid, the sodium will come up really quite promptly, and they'll get out of danger quite quickly without the need for hypertonic saline. Okay, next case. 38-year-old man diagnosed with squamous cell carcinoma of the head and neck 2 months ago and has known chronic SIADH. On a routine clinic visit, he reports some subtle impairments in his ability to think clearly, and he has a sodium of 119, urine sodium is 116, potassium 47, urine osmolality 464. Which of the following would be appropriate in the management of this patient? Hypertonic saline to raise serum sodium by 14 milliequivalents per liter in the first day, fluid restriction and salt tablets, tolvaptan to raise serum sodium by 2 milliequivalents per liter per hour, normal saline at 125 an hour, or normal saline and metolazone. Okay. Yep, so most of you chose B, which is obviously the obvious initial step in this patient. So in the treatment of SIADH, we have an armamentarium of things that we can use now. The important thing is that if a patient has an acute drop in their serum sodium or has significant symptoms like seizures, then you want to raise the sodium faster, for example, with hypertonic saline. And I include tolvaptan in there because those of you who have used that will probably have noticed that sometimes these patients' sodiums come up quite rapidly. For chronic hyponatremia, the things that help are reducing the amount of fluid that they're taking in. I never restrict free water because all drinks essentially are free water, whether it's actual water, milk, juices, soda, even Gatorade is mostly hypotonic. So other than very salty soups, everything's free water. Sometimes if they're not responding to fluid restriction and or salt tablets, which is another good chronic treatment, I also give urea powder now. What's not helpful is isotonic saline. And so this is just a reminder that some patients who have SIADH can get a phenomenon known as desalination. So this comes out of this misconception that because a patient has a low sodium of 119, if you give normal saline, which has a sodium concentration of 154, surely that would raise their serum sodium, right? Well, no, because it all depends on what they're putting out in their urine. So, for example, in a patient like this, whose urine osmolality is quite high, 464, and is composed of sodium, potassium, and urea. So I didn't put the urea here because it's an ineffective osmol. So what we're really interested in is the tonicity of the urine. And that's essentially the sodium plus the potassium multiplied by 2 for any accompanying anions. So in this case, the tonicity of the urine is 326. So it's actually higher than that of serum and higher than that of normal saline, okay? And so if you give this patient normal saline, tonicity of 308, and they put out urine with a tonicity of 326, they would actually lower the serum sodium. So the more saline you give, the lower the serum sodium gets, which is the opposite of what you want. and that's being called desalination. And it essentially only happens in patients with SIADH. So isotonic saline only helpful if the urine sodium plus urine potassium is less than 150, or 2 times the sodium plus potassium is less than 300. Okay, so the other issue that this question alludes to, which Dr. Mount also mentioned, is that you want to avoid osmotic demyelination in patients with chronic hyponatremia. And the population at risk are those who've had hyponatremia for more than 48 hours, which this patient clearly had. There are a number of guidelines on how fast to correct the sodium, and I don't think there's any one guideline that's considered official for the boards. And as Dr. Mount mentioned, it's a moving target. But here's one from Joe Verbalis that I find quite helpful, which is that in patients at high risk for osmotic demyelination, restrict the correction to 8 in the first 24 hours. For normal risk, 10 to 12 in the first 24 hours, and 18 in 48 hours. And that seems to be a reasonable guide that I think most nephrologists would agree is appropriate. Okay, moving on. So an 18-year-old female college student runs the Boston Marathon. It's her first marathon, and she's careful to keep well hydrated before and during the race. But at the finish line, she feels severely nauseated, dyspneic, and has generalized headache. On exam, she's lethargic, dyspneic, and confused, but well hydrated. And her point of care sodium is 112. Which of the following would be the best initial treatment? A liter of normal saline, fluid restrict and observe for 1 hour, salt tablets, 100 ml of hypertonic saline, or a liter of sports drink. Okay. Excellent. So most of you chose the hypertonic saline. There was a handful that chose the normal saline. And so the reason that, well, let's see if we have the slides. Yeah, so this is obviously exercise-associated hyponatremia. We know that in patients that have exercise-associated hyponatremia, as shown in this figure from the New England Journal paper by Almond, that these patients have increased weight gain over the course of the race. So the point is they're not patients who are dehydrated, they're patients who are actually overhydrated with fluid. But in addition, and here's the key thing, if you measure the ADH levels in the urinosum, it's actually high, not low. So these patients are not behaving like psychogenic polydipsia, presumably because of the stress of the exercise. They're actually also behaving like they have some transient SIADH. So if you give a patient like this isotonic saline, you would actually potentially risk causing desalination. So the recommendation is to give hypertonic saline. This is obviously a patient that has acute symptomatic hyponatremia, so they need rapid correction. And one of the recipes that's considered to be easy to remember and safe is to give 100 mils of 3% saline over 10 minutes. That raises the sodium by about 2 to 3, and you're allowed to repeat that as needed, depending on the serum sodium. Okay, a 66-year-old female with non-insulin dependent diabetes presents with several days of malaise, lethargy, polyuria, and decreased oral intake. And on exam, she looks dry, let's say, and her potassium is 5.2, bicarb is 25, creatinine is 1.8, serum glucose is 975. After initiating insulin and 2 liters of isotonic saline, which of the following would be the best treatments to normalize the patient's serum sodium concentration? Is it hypertonic saline, oral fluid restriction, hypotonic saline, tolvaptan, or salt tablets? Okay. So most of you chose C, which is hypotonic saline, which is indeed the correct answer. So let's see if I have a slide here. So you can get hyponatremia with hyperosmolality in patients who are hypoglycemic. And here, the low serum sodium is simply a manifestation of translocation of water out of the cells in response to the hyperglycemia. So we quote unquote correct for this by adding 1.6 to the sodium for every 100 mg per deciliter increase in glucose. And so this essentially tells us not what the real sodium is, but what the sodium would become if you were able to treat the hyperglycemia and normalize the serum glucose. And when you do that in this case, the increase in glucose is 875, so we correct by 8.75 times 1.6. Add that to the actual sodium, and you get that the patient would become hypernatremic, which isn't uncommon in hyperglycemic patients and is due to the glycosuria and osmotic diuresis. Next case, a 74-year-old female with a history of hypertension, hyperlipidemia, and depression is admitted with unsteady gait and fall at home. These are her meds. She's euvolemic. Sodium is 117. These are some of her lights that you can look at for a second. Urine sodium is 58, urine osmolality is 230. Okay. Which is the most likely cause of her hyponatremia? Pseudohyponatremia, adrenal insufficiency, hypothyroidism, ADH secreting tumor, or adverse effect of meds. Okay, last chance to weigh in. All right, so most of you chose E, which I agree with. So this is a patient who's got inappropriately concentrated urine. So here's where it's really critical to know that that threshold is 100. Even a urine osm of 220 is inappropriate in the setting of hyponatremia. This patient is euvolemic, doesn't seem to have either dehydration or heart failure or liver failure. So SIADH would be a good bet. Could be hypothyroidism, but the TSH was normal. And the key here is she's on an SSRI, so it's highly suspicious that that might be the cause. In a fairly old now case control study of hyponatremia among patients taking antidepressants, you can see that the odds ratio for developing hyponatremia was very high in patients that were on SSRIs, especially if they were elderly or on a diuretic. And if they had all three, they were almost destined to develop hyponatremia. Okay, next case. A 48-year-old female with small cell lung cancer has been noted to have a low serum sodium for 3 months. She presents to the ER with nausea and inability to tolerate oral fluids. And on exam, her weight is 55 kilos. She appears mildly hypovolemic but alert and oriented. She comes in with a sodium of 108, urine osmolality of 800. She gets 3% saline at 200 mils an hour. And 5 hours later, her serum sodium is 122, but her mental status is unchanged. Which of the following would be the most appropriate next step? Change the rate of 3% saline to 80, discontinue fluids and initiate tolvaptan, discontinue fluids and initiate 1 liter of oral fluid restriction, discontinue hypertonic saline and start 5% dextrose at 250 mils an hour for 4 hours, or none of the above. Okay. So most of you chose D as the best answer. So there are a number of potential things you could do here. But A, B, and C are obviously not going to cut it, and E, doing nothing, is also incorrect. So this is obviously a patient who's been overcorrected, been corrected too rapidly, and is at risk of developing osmotic demyelination syndrome. As you know, there are a number of quite convincing animal studies. Here's one of these rat studies that show that if you correct too rapidly with saline and increase the sodium up to 137 in 24 hours in rats, that all of them develop neurologic manifestations and all of them die. But in this particular study, if you lowered the sodium back down to 117 by 24 hours, most of them survived and had no neurologic changes. So there's convincing data that lowering the sodium in patients who are overly corrected is beneficial. The question is, how could you do that? And then most people would use desmopressin 5% dextrose. As you heard earlier this morning at the Brigham, they're now doing a lot of desmopressin plus 3% saline, but that would be something that you would start right in the beginning to prevent overcorrection. Next, a 30-year-old female with anorexia nervosa is found on routine lab exam to be hypokalemic. So now we're going to talk about a few potassium cases just to whet your appetite before Dr. Mount's next lecture. And her K is 3.2, bicarb is 32, creatinine 0.6, 24-hour urine shows a liter of urine with 80 of potassium, 54 of chloride, and 300 of calcium. Which of the following is the most likely cause of this patient's lab findings? Loop diuretic abuse, laxative abuse, Gittleman syndrome, thiazide diuretic abuse, or surreptitious vomiting. So figuring out the cause of chronic hypokalemia is one of the most challenging things we get to do. And let's see what people thought here. Whole range of answers. Okay, so let me explain my reasoning for why A would be, of these choices, the most likely, other than that I have a nasty, suspicious mind and patients do just about anything. So when I get a patient of hypokalemia, these are the three general causes that I think about. So urinary potassium wasting, GI loss, or cellular shift. So shift of potassium into or out of cells, into cells in this case, doesn't usually cause chronic hypokalemia. It causes transient acute hypokalemia. So that's unlikely to be the cause here. GI losses, so patients who abuse laxatives or surreptitiously vomit, one can sometimes have hypokalemia that would otherwise be unsuspected. So the key here is to determine, do they have urinary K wasting? And there are a number of urine indices for this. For the purposes of the boards, currently they're always giving you 24-hour urine potassium, which is supposed to be the gold standard. And urine potassium more than 25 milliequivalents per day is considered to be inappropriate in the setting of hypokalemia and suggest urinary K wasting. If you like, you can use the transtubular K gradient, the urine K to creatinine ratio. What you mustn't use is just a spot urine potassium concentration, because that could be just about anything, depending on whether the urine is concentrated or dilute at the time. And remember that hypokalemia itself impairs the ability to concentrate urine. Okay, so this patient had urinary K wasting. Then I divide them to those patients that also have hypertension. So if they have hypertension, urinary K wasting, assuming they're from the same cause, this is due to some form of hyperaldosteronism. So either they have primary hyperaldosteronism or they have a response in a tubule that mimics hyperaldosteronism. For those patients who are normotensive or volume depleted, most of them also have a metabolic alkalosis. There are a small number that have an acidosis, and there's a short differential for that. diarrhea, RTAs, toluene abuse, ampho. All other patients are in this category. And there are basically two general causes of hypokalemic metabolic alkalosis with normal volemia. Either it's due to surreptitious vomiting, or it's due to renal tubule salt wasting in a part of the tubule that's upstream of the collecting duct. And the key to distinguishing between them is to measure the urine chloride. So the urine chloride in this case is the marker essentially of volume depletion. And in the setting of metabolic alkalosis is a better marker than urine sodium. Low urine chloride suggests vomiting. High urine chloride suggests renal salt wasting. And then here, this is a more subtle point that may or may not ever come up on the boards, but if the salt wasting is in the loop of Henle, it causes hypercalciuria. So that's what you see in patients with Bartter syndrome, the genetic form of this. That's what you see in the pharmacologic cause of this, which is loop diuretic use. If the urine calcium is very low, then that's what you see in Gittleman's, and of course with thiazide use, which we often use to actually lower urine calcium. So this patient fell into this category. Patient could have had Barter's. Usually this is a disease of infancy, and it wasn't a choice on this set of questions. Okay, next. 23-year-old male is referred for workup of newly diagnosed hypertension. He's otherwise asymptomatic, family history non-contributory. That's his blood pressure. He's a little bit obese, and he's got a K of 3, bicarb of 29, renin is 0.7, aldo is 3.9, and 24-hour urine K is 65. Which of the following tests would be most likely to be helpful in this diagnosis? Is it serum metanephrines, Doppler of the renal arteries, 24-hour urine aldo, 24-hour urine 18-hydroxy and oxocortisol, or 24-hour urine cortisol? And as I said, you'll get a little bit more detail about potassium in the next lecture after the break. Okay, so you were kind of divided between C and E. E, I think, is the correct answer, 24-hour urine cortisol. So going back to that branch point, a patient who's hypokalemic, usually metabolic alkalosis, but is hypertensive, we think those patients most likely have hyperaldosteronism. In that setting, measurements of aldo and renin are critical. So if the aldo is high, but the renin is low, those patients have primary hyperaldosteronism. So either hyperplasia or an adenoma of the adrenal that's secreting too much aldosterone, driving the hypokalemia and hypertension, and then secondarily feeding back and suppressing renin levels. If renin and aldosterone are both high, this is a form of secondary hyperaldosteronism. And the most common cause of this is renal artery stenosis. So you decrease perfusion to the kidney, the juxtaglomerular apparatus responds by secreting more renin and hence driving more aldo secretion. And then this arm is those patients in which renin and aldo are low, and they have some condition which mimics aldosterone. And by far the most common one is Cushing's disease. So patients who have very high cortisol levels. So remember, the mineralocorticoid receptor also responds to cortisol. The reason that it doesn't under normal conditions is because cortisol in the collecting duct is metabolized by an enzyme that degrades it. But if you generate enough cortisol, then that overcomes that degradation and causes hyperaldo-like symptoms. And in this particular patient, that would be the first thing to suspect. So here are the more small print things that fall into this category. So there's an inherited disorder called glucocorticoid remediable aldosteronism that mimics primary hyperaldo. Malignant hypertension in the acute phase can look just like secondary hyperaldosteronism. The very rare condition of a tumor that secretes renin can behave like this. And then over here are these things that mimic high aldose, but the aldose and renins are completely suppressed, including Liddle syndrome, licorice ingestion, the syndrome of apparent mineralocorticoid excess. And so this patient was in this group, and you first have to rule out Cushing's before you start searching for the rarer disorders. And this is to remind you of some of the tests that you could do for these. So one of the answers on this question was urine 18-oxo and hydroxycortisol. Well, that's to detect glucocorticoid remediable aldosteronism. Okay. A 19-year-old male student visiting from Taiwan presents to the ER with acute flaccid muscle weakness. Otherwise looks fine, supposedly not got diarrhea, vomiting, or using meds. His K is 1.7, and his urine potassium is less than 5. Which of the following would be appropriate in the management of this patient? Repletion with potassium, 160 milliequivalents a day, loperamide, indomethacin, check TSH, or none of the above. Okay. All right, so most of you chose D, which I think is a reasonable solution. So the point here is this is a patient that has profound hypokalemia and almost no potassium in the urine. So it's clearly not urine K wasting. The symptoms were fairly acute, so it looks like a cellular shift. And so this picture is suspicious of hypokalemic periodic paralysis. And in particular, thyrotoxic hypokalemic periodic paralysis is relatively common, occurs predominantly in Asians, particularly males between the ages of 20 to 40, and is associated with development of thyrotoxicosis, but behaves just like the familial form, being precipitated by meals and exercise, repetitive hypokalemia, and recovery, which can be either spontaneous or with propranolol. Okay, so the point here is these patients are not whole body K depleted, and giving large amounts of K repletion is potentially dangerous because it can cause hyperkalemia. Small amounts of K repletion are fine, and obviously to detect the underlying cause, you would want to check thyroid function. 67-year-old male with hypertension for 30 years has been having worsening blood pressure control. These are his current blood pressure meds. BP is still high. His K is 3.4. Bicarb is 27. Renin is 5.3. And plasma aldo is 14. Which is the most likely cause of this patient's hypokalemia? Is it reninoma, adrenal corticoadenoma, renal artery stenosis, ingestion of licorice, or Gordon syndrome? Okay. All right, excellent. So most of you chose C, which seems to be the most likely cause. So again, this could be hyperaldosteronism, perhaps superimposed on previous essential hypertension. And if the renins and aldos are both on the high side, it's suspicious of renal artery stenosis, a very common problem in the elderly. And as I said, commonly we see this superimposed on prior essential hypertension, which is probably what happened in this patient. Case 19, 25-year-old male, elevated blood pressure. His mom had high blood pressure from childhood, K of 3, and bicarb of 29. And here the renin is 0.2, aldo is 2.5. Urine cortisol is normal, and the urine-free cortisol to cortisone ratio is also normal. Which of the following would be most effective at lowering blood pressure? Amiloride and spironolactone, amiloride but not spironolactone, phenoxybenzamine, renal artery angioplasty, or adrenalectomy. Okay. And good. So most of you chose B, which is the correct answer, amiloride, but not spironolactone. So the idea here is this patient has suppressed renin and aldo, does not have Cushing's, and the cortisol to cortisone ratio in the urine is normal. So this is not syndrome of apparent mineralocorticoid excess or licorice ingestion. So most likely this patient has Little's, overactive ENaC. And so the treatment for this is to block ENaC, which is what amiloride does. Spironolactone does not work because the ENaC is overactive and no longer responsive to the mineralocorticoid receptor. And so the typical thing you find in Little's is they respond to amiloride, but not spironolactone. And last question, 17-year-old with symmetric thigh weakness, normal blood pressure, K of 2.8, urine K is 40, urine chloride is 55. And the question is, what's the most likely diagnosis? Is it Gittleman's, familial hypokalemic periodic paralysis, hyperthyroidism, bulimia, or adrenal adenoma? Okay, let's see what you guys thought. Okay, so most of you thought Gittleman's, which I think is exactly right. So again, here's a patient that has urinary K wasting. They're normotensive, metabolic alkalosis, and they have a very high urine chloride. So if it's either diuretic abuse or Gittleman's or Barter's, and in this case, Gittleman's was the best choice. So with that, I think I'll stop. Thank you very much.